The material in this podcast has been made possible with the financial support of Sun Pharma Canada Inc. Defocus Media has maintained full editorial control over all the content of this podcast. Hello and welcome back to another episode of the 2020 podcast, Canada's #1 optometry podcast. I am your host, Dr. Harbir Sian. Thank you so much for taking the time to join me here to learn and to grow. As always, I am truly, truly appreciative of all the support. Everybody I speak to who gives me feedback on the podcast, all the comments and reviews online is incredibly supportive, and I really, really appreciate it. And as always, I always ask a little favor right off the top. If you do get some value from the podcast, from any episode that you've heard, please do share it, tell a friend, throw it up online, on social media, wherever you can. Again, I appreciate all the support. It's really been helping the podcast grow, and it helps me bring on amazing guests like today's guest, who is Dr. Bruce Jackson. Now, before I get into the introduction for Dr. Jackson, if you didn't know, July is Dry Eye Month, and so Dry Eye Awareness Month. So we are going to do this podcast really digging into the ins and outs of dry eye to sort of commemorate this special month. I actually didn't know that until recently, so I want to make sure that we do this Dry Eye Month, Awareness Month justice here. And Dr. Jackson is absolutely the perfect guest for this conversation. But Dr. Jackson obtained his MD in 1967 at the University of Western Ontario, when he completed his residency in ophthalmology at McGill University in 1972. In 1986, he became the ophthalmologist in chief at Royal Victoria Hospital, which is the hospital at McGill University. And 1987, he became the chairman of the Department of Ophthalmology. Since then, there's been a lot happening in Dr. Jackson's career, but in particular, he started the Excimer Laser Program at the Eye Institute in 1992, carrying out clinical research and in the treatment of myopia, myopic astigmatism, hyperopia, and hyperopic astigmatism, and Presby LASIK from 1993. His research interests are in bacterial and viral infections of the external eye, new antibiotics and antivirals, and ocular surface disease, especially dry eye disease. Dr. Jackson has a huge list of accolades, and I really do want to mention a few of them because I think it's just important to recognize, these types of achievements. Here's a few of them. I'll just list a couple quick ones here. Eye Physicians and Surgeons of Ontario Lifetime Achievement Award in 2017, Canadian Ophthalmological Society Lifetime Achievement Award in 2012, the Ottawa Life Sciences Council Career Achievement Award 2006, the Queen's Golden Jubilee Medal recipient in 2002, and there are a few more. I feel like the only thing that's missing, Dr. Jackson, is the Queen tapping you on each shoulder with a sword here to give you a knighthood. What do you think? Is that due at some point soon?
No, I don't think so.
Well, thank you, Dr. Jackson, for joining me. Honestly, truly an honor to have you. I've had some pretty special guests, but to have someone as distinguished as yourself is really wonderful, especially when we're going to be talking about this condition, dry eye, that you are truly an expert in. So thank you for taking the time.
I'm delighted to.
So Dry Eye Awareness Month is July. Why don't we start with a little introduction for yourself, Dr. Jackson, from your perspective of who you are and what you do.
I started in ophthalmology, and I thought that, in fact, that I would probably not do much in the way of clinical, but be more on the research side. However, once I got into the program and then did a fellowship at the Proctor Foundation in California, I returned to McGill and really enjoyed practice and teaching residents and ultimately starting a fellowship program. I tried to get involved in research, but it was really when I moved to become Director General of the University of Ottawa Eye Institute, we had a chance to develop a really good corneal unit with basic scientists and also be able to start the Excimer laser program. And at that time, that was the most controversial of anything, to have a new eye institute start into something that was really only in the private world. And the question was, does it work or not? And so our research over all those years was really to show that it was a great benefit. And there was a tremendous amount of spin-off that we got learning about dry eye, ocular surface disease, refractive changes. And basically, it was a great tool for training residents and fellows and ophthalmic technicians.
That's wonderful. And I think actually that's where I kind of wanted to start was you have this amazing experience in the research realm, but also obviously in refractive surgery, in dry eye, in ocular surface disease. And all of that does, of course, come together in many of our patients. And I was really interested to hear a perspective on, treating dry eye in preparation for refractive surgery and how important that's becoming. Is that becoming more important over time? And how important is that now?
Let me take you back to 1995. And we
actually
started to do hyperopic PRK. And what we soon saw was that these patients who were really perimenopausal women, predominantly, who wanted to get rid of their glasses so that they could put on their makeup more easily, basically had fluctuating vision after surgery. And if you put in an artificial tear, had them blink a few times and read the chart again, you often got one or two more lines of vision. So we realized that by steeping the cornea, these eyes were drying and we had tear instability. And so that was really that first sort of recognition that refractive surgery could really change the ocular surface. And we started to look much more carefully at the patients preoperatively to make sure that they did not have a rapid tear breakup time, that they didn't have corneal staining or other signs of dry eye.
So that's a lot longer ago than I expected. 1995 is taking me back to high school, I think. But since we're talking about the history of it, is that when you found in yourself, that's when we started to recognize dry eye more? Or was it an earlier stage when the medical community as a whole sort of recognized dry eye as an actual disease?
When I first did my training, we looked at dry eye as just basically a lack of tears, an inadequate volume of tears was really it. And so we understood that Sjogren's syndrome wasn't autoimmune and that there were T-cell infiltration that actually basically shut down the lacrimal and accessory lacrimal glands in this group. But we really didn't recognize this as an inflammatory condition until basically Allergan did the clinical studies with Restasis. And the associated research after that really showed that we were dealing with an inflammatory ocular disorder. And so by 2007, the dry eye workshop, the first one, basically included that this was a multifactorial disease of the basically tear filament ocular surface. And so it really took that period of time for us to realize that it wasn't just an adequate number of tears, it was the composition of the tears, and that this was an inflammatory process that was driving this.
Yeah, and so in 2007 that was the first Dews report. When was the Allergan study conducted?
The Allergan study was done around 1998 in that realm. We took part of that in McGill. And then fortunately, we had a number of patients that really did well on that study. And so the government basically gave us a special access program so that we could continue to use cyclosporine or Restasis on these patients. The supply was come and go. You sometimes would have it, sometimes not. And so some of these patients would be doing great, and then we couldn't get it for 2 months. No. And you could see the regression that occurred. And then when they got back on again, basically how happy they were with symptom and sign improvement. So it really drove home the point that properly selected patients really did improve on anti-inflammatory treatment. And cyclosporine was the first one that we had. Up until that point, Yes, we used some steroids for the severe cases, but had to be short-lived because of pressure and cataract concerns. And so when cyclosporine came along, we had a safe drug that we could use long-term.
So I'm a little bit of a historian, I suppose you could say, or at least I enjoy learning about what happens, the history of certain things. And I've already, a couple of my questions have kind of been like, when did this start? So where did cyclosporine even come from? So we're saying that perhaps, doctors the medical community started to recognize dry eye sort of towards the late 90s as an actual inflammatory type of condition. But where did cyclosporine just come? Was it being used somewhere else where they said this could be reapplied on the eye?
Well, there is a spontaneous dry eye that occurred in dogs. And I'm not quite sure why the veterinarians got involved, but they started to use it and we sort of picked up on it. And one of the chaps in New York, Hank Perry and myself started to formulate cyclosporine and try it in some of the dry eye patients. And it was interesting that in discussions with Allergan and part on a chairlift at Snowmass, Colorado, prompted them to take a real serious look at what cyclosporine might be able to do in the treatment of dry eye. And from that, we've just learned a ton of information regarding this inflammatory cycle. And again, we recognized it in refractive surgery, the importance, and then cataract surgery became a refractive procedure. Right. And with premium IOLs, with toric lenses, we realized that we had to have accurate keratography. If you took a topography, for example, you could see some patients with severe dry eye just basically on the images. Mm-hmm. And so it became a really important part of patient satisfaction, getting a good post-op result. The other interesting thing was that there was a study, it's been called the Faecal Study. And although it was done in sort of the 13, 14, it didn't get really published by Bill Trattler until 2017. But what was really interesting in that study was that about 60% had no symptoms when they were going for cataract surgery of dry eye. But in fact, about 63% had a rapid tear breakup, less than 5. 50% had central corneal staining, and almost 3/4 had some form of corneal staining, and close to 20% had decreased Schirmer's. So that really put a perspective of what a problem we really had in patients going for cataract surgery who are older, may not have symptoms, but in fact do have evidence of ocular surface disorder. And then you compound that with patients who are on glaucoma drops with preservatives. And so you have sort of the perfect storm where you might get toxicity from the preservatives, from the glaucoma drops on top of a dry eye. And so this is why it's become so important if we're really going to have patient satisfaction after cataract surgery.
Yeah. Circling back to that initial question, right? Especially when it comes to cataract surgery being, I kind of lump them together, to be honest now. Laser surgery, cataract surgery are just refractive surgeries as far as I'm concerned, because surgeons can really have fantastic visual outcomes, refractive outcomes with cataract surgery if it's all done well. But that's why it's so important, is because often the patients who are getting cataract surgery have this perfect storm of, the deteriorating ocular surface plus the medications, oral and topical medications that can cause more dry eye. Like, just all of that needs to be addressed. So you're telling me that Restasis came into eye care because of a conversation that you had on a chairlift, which is fine, because we know that's where a lot of business.
But yes, I mean, we were really pushing them to take a really good look at it, and fortunately they did. And but we really didn't understand a lot about symptoms and signs of dry eye in those early days, and so. I mean, when you look at those early studies, they were aimed at the more severe patients. And if you really stop and think of it, they were using Restasis twice a day, but with no other drops. I mean, there was no other therapy. And we know you can't treat dry eye with just cyclosporine twice a day.
Right.
And so it's multiple treatments to really achieve a good result. So the fact that they could demonstrate improvement, and it took until 2003 for the FDA to approve it in the States based on increased tear production. Canada didn't accept that. And so it really took a subgroup analysis to show that both symptoms and signs improved, and it got approved in Canada by 2010. But again, properly selected patients were the key. And so when it first comes out, everybody gets on it, and then there's failures. And you say, well, why didn't this patient improve? And then you have to really look, what is patients that really do benefit from anti-inflammatory treatment?
Right. Yeah, definitely. I know early in my career, I felt some of those failures as well, because I thought, wow, this is the magic drug. I'm going to put every dry eye patient on it. Of course, that's not how it works. But since we're doing the history of pharmaceuticals here, Restasis, of course, was kind of the first one of these pharmaceutical agents to treat the inflammatory side of dry eye. What came after that?
So it was interesting. Restasis was approved 2010. 7 years later, 2017, lifitegrast or Xiidra was approved in Canada. And again, this was a little different immunomodulatory drug. It acted differently than cyclosporine on the LFA1 to ICAM binding. But it again acted on the T cells, decreasing recruitment, cytokine release. And it really did help a number of patients with their symptoms more than signs. And I call it my love or hate drop. Either patients love it and will hug you for putting them on it, or else they'll return the box and say that the side effects were just too bad, of the dysacousia, the stinging, the blurred vision, that they just couldn't continue with it, even though it might have made a little improvement. So I found it more useful in the evaporative dry eye than the aqueous deficient dry eye. And again, more for the symptoms. And then in 2021, Cequa by Sun Pharma was approved as a new formulation of cyclosporine. And the exciting part of it is it's almost double the concentration at 0.09%. So it's like using Restasis 4 times a day when you only have to use it twice a day. And then the formulation is really novel, where they use this nanomicellular technology to encapsulate the cyclosporine as a sort of a core with a shell of a water-soluble polymer, such that it gets into the tear film much more quickly, and that it looks like it penetrates the cornea and the conjunctiva considerably faster. So we're getting much more efficient drug delivery to the eye. And we've really just started to use it since this spring. But I certainly have had a few patients now that were unable to use Restasis that are finding it more comfortable, and basically are showing some good results. So it's always nice to have options. And we did have another one. Santen had Icurvis, which is now approved for vernal, which is Vercasia, and it was also 0.1% cyclosporine, but again an emulsion, little different vehicle, but that didn't really get approved by Health Canada. So at this point in time, Cequa is our newest one to use.
Gotcha. And you did mention, well, just for anybody, you're mentioning earlier with Restasis and any of these medications, you can't simply use the medication on its own and expect that to fix all of the symptoms and everything that the patient's dealing with. Usually there's a multifaceted approach, right? As we know from the DEWS definition, it's a multifactorial disease. And we'll get into that a little bit more later on. What would be sort of the holistic approach here? But just speaking about the pharmaceutical agents, I think you touched on it already, but what would be sort of the benefits of Cequa versus the traditional, cyclosporine Restasis 0.05 versus 0.09? You mentioned obviously the higher concentration. Are you finding that patients are tolerating it better? They're not getting as many of those symptoms or the side effects that they were getting with Restasis?
It's pretty early for me to really make a comment. The ones that I really have put on at this point in time are patients that have failed on Restasis. And those that, are doing well on Restasis, I just leave them on it. But those that have failed have had to discontinue. I'm having some good success in getting them started on Cequa. And some of the new patients coming in that will certainly put on Cequa. And so far, they've been doing quite well. So, the different formulation may make a big difference. Another point to be made is that generic cyclosporine was approved in Canada.
Right.
Much to a lot of people's surprise, because we have no idea what the emulsion is. And I had a number of patients that were switched by the pharmacy and came in, and they weren't doing as well. They had a lot more symptoms. And then I realized that they were on the generic form, not on the brand name form. And so once we switched back to the brand, they improved. So there is a group that may not do as well on the generic. And so I just point that out when people say they're on cyclosporine, what are they on, is important. Allergan has the multi-dose bottle. And so that one is not genericized. So that is one that can be prescribed and not get the generic for it.
Yeah, that's a really important point, actually, to confirm if your patients are not doing well on Restasis, to confirm whether they're on the generic or the branded one. And is the multi-dose, is that available in Canada? I didn't even notice that.
Yeah, I think it was around 2018 it was approved.
Oh, wow.
I was on the advisory for that, and we thought this was going to be great, that patients are going to love the multi-dose, just one bottle they can carry around, use it for a month. But interestingly enough, patients like the vials. They could carry them around. They could leave them all over the place, in the office, at home, so that they didn't forget it. And a number of them did vial spare, and so they could get more out, whereas there was just enough for 1 month in a bottle, especially when patients didn't have insurance and were paying for it. So I have a few that like the multi-dose, but I must say that the majority are still back to the minims, and that's the way Cequa is as well. It uses the minims.
Yeah, that's interesting. I got similar feedback, from a lot of patients when I'm trying to switch them over from the single dose or single use preservative-free drops, whichever preservative-free artificial tears, over to a multi-dose. And initially they say, oh, that sounds like a great idea, except exactly what you said. I like to keep a couple in my pocket, a couple over there, and then, like you said, reuse them so they get a little more out of them. So that does make sense. That would be a common issue there. Moving on, then again, understanding that this is a multifactorial condition that we're talking about. I know you and I talked in the past, and you wanted to really stress the importance of recognizing the relevance and the role that lid disease has to play on ocular surface disease and dry eye. I'd love if you could just kind of go into that, where blepharitis comes in and other types of conditions, lid conditions come in, and how we could recognize them.
Sure. One of my mentors at the Proctor Foundation, Dr. Richard O'Connor, used to give a lecture, and he'd start off on blepharitis by saying it was poorly diagnosed and poorly treated, and it still is exactly the same today. I think that, if a patient comes in with crusted eyelids, scurf, debris, sleeves, on the lashes, we recognize that as blepharitis, and we know that cleaning the lids using an antibiotic, occasionally an antibiotic steroid, will settle these down. And so that really hasn't changed much over the years for the anterior blepharitis. And often, in adulthood, you get a history that as a child, they had crusted eyelids and styes and that. I think that what really did change was meibomian gland dysfunction. And we did recognize the role of the meibomian glands, especially when patients came in with frequent chalasia and you could see obstructed glands. And I used to remember at the Royal Vic, patients would come in and we would do meibomian gland expression after warm compresses and put these patients on tetracycline, for example. But we really didn't recognize the role of lipids in the tear film, so the same way as we eventually did, and how really lid disease probably accounts for 50 or 60% of dry eye with the tear instability. And, only about 10, 15% really have aqueous deficient, and the rest are basically a mixture. So we now know a lot more about the role of meibomian gland dysfunction, and also the role that rosacea plays within this. And atopic dermatitis, for example, are all additive risk factors for it. But, it's really that tear instability that really starts this whole inflammatory cycle. So, the lids play such a major role. And I remember at one point we used to talk about conjunctivitis meibomiana. This was a conjunctivitis from the old days where the eye would get red and get inflamed a bit, and you'd look and you'd find nothing, and except that there may be a few little changes on the lid margin. And we just didn't recognize that there was that inflammation that was going on that was really the cause of this.
That's so interesting, because now, that's such a key factor. As you mentioned, for so many patients, the underlying issue is this meibomian gland dysfunction, leading to the tear film instability, and then the inflammation. This is a conversation I have so many times every day with patients. They come in and their complaint is they're getting a sharp pain, a few times throughout the day. And I have to go through this. I'm like, let me rewind the clock here and tell you how this all started. And then it got to this point, and they have a hard time. I try my best to show them visuals and all these things, but they'll be like, no, it just started a couple of days ago. But trust me, this has been going on for a long time. Your symptoms just started a few days ago. So it's interesting to hear, that physicians were not at that particular time connecting the dots, but now we know that it's so vital. So when we talk about a more kind of rounded approach then to treating dry eye, what would you say on the average patient that you're seeing who has this sort of mixed causes of dry eye here, sort of aqueous and evaporative? What kind of treatments are you seeing most commonly for these patients?
Yeah, at the moment, I'm practicing in a community, and so we don't have a lot of some of the new technologies available. So we're really back to almost where we were. I think that, we've been able to show that warm compresses done effectively, lid massage, basically keeping the lid margin clean. And now we have pre-moistened wipes, and some with tea tree oil if we suspect Demodex. We've got the use of antibiotics, but erythromycin, a lot of the staff are resistant to it. And so I tend to use fucithalmic or fusidic acid for some of these patients. And really a discussion on omega-3s. And we also have eye drops that have oil, and basically in them to help the tear film. We used to use lid scrubs with baby shampoo, but that's we've got better ways to do it than that. Yeah. And so I discourage that. But if you look at that combination of things, including the artificial tears, and I have a discussion on the omega-3s with patients. We know some do really well on them and others have found no effect. So I give the patient the choice of using a medical grade one to see if it will make a difference over about 3 months. In about 80% of patients, that alone will make an improvement if they actually do it. Yeah. But what happens is like flossing your teeth, and they start to feel better, and then gradually they just drop off. And so Men don't like doing warm compresses and that, so I have them do it in the shower and just let the warm water hit the closed eyelids and massage in the shower, and that's a little bit better way for doing that. But that's sort of the basic treatment that we need. And then depending upon whether they have marked rosacea, I'll often put these patients on doxycycline and low dose doxycycline. And it's amazing, some will really improve with that. Their symptoms of dry eye almost completely disappear with that as an anti-inflammatory. While in some patients, it doesn't seem to make a difference. And so for those unable to take tetracycline, I use azithromycin, and occasionally you can use compounded azithromycin on the lid margin to help as well. So, I mean, that to me is sort of the basic approach to the lids. And then we get into those that just don't respond to that. And then for that group, I mean, we've got a lot of new technology. I think the first one was the LipiFlow that really showed that thermal pulsation, if you warm those lids up to about 42.5 degrees and you were able to express the meibomian glands, that these patients really did have symptomatic improvement, and we did see parameters change in the tear film. So the problem is it was expensive and it didn't last, and it wasn't a permanent cure. So other procedures came along like that. For example, for rosacea, we've been using intense pulse light, the dermatologists have for many, many years. And that has an anti-inflammatory effect, anti-demodex. And so that shows really improvement. Again, not a cure, and often has to be repeated and or combined with meibomian gland expression. And so we have a number of these techniques where we're really trying to warm the lid, essentially express the meibomian glands. We know that the meibomian glands get keratinized, so therefore there's a number of procedures to try and basically debride the surface, whether it's mechanical, and even gone to the point of Maskin developed a little probes for meibomian gland probing. And I must say, I did spend a few hours probing meibomian glands, but I decided this was not going to be a procedure that I was going to continue with. So, but again, it goes back to that same concept. We've got to warm up the lids. We've got to try to open up the meibomian glands, express them, and then hopefully change that lipid flow so we get a better stability of the tear film. And at the moment, things like doxycycline, azithromycin are certainly ways that seem to alter the meibomian gland function.
Yeah, that's great. And if you wouldn't mind sharing sort of if you can, the mechanism of action for something like a doxy, when you give somebody oral doxy, what do we understand is happening?
Yeah, I mean, basically, I tell patients, and they're always concerned. I said, we're not really using it for its antimicrobial effect. Yes, in low dose, it probably does have a little, but it really inhibits MMP9. And so MMP9 is really a product of IL-6, and it really is responsible for causing the apoptosis and corneal cells. And so I use it pretty extensively on patients who have corneal disease, because it really does inhibit the MMP9s. And you can, on patients with lid disease, you could do the inflammadry and show that they are positive for MMP9. And so using doxycycline really reduces that. So I use it as an anti-inflammatory. And then I try to use it in as low a dose as possible. Certainly Accolades is a good one for those that have insurance. And for those that don't, I'll take doxycycline, for example, and just use the pill, have them cut it in half and just take half a pill a day. Yeah. And that's often enough to maintain their symptom-free level of comfort.
Gotcha. Great. Often there's other conditions that will mimic dry eye. We call them masquerade, in different areas of medicine, we'll have masquerade syndromes or conditions. Are there some for dry eye, and what types of conditions are they? And how do we sort of distinguish those from your typical dry eye type of condition?
I have a fun practice because I really get the referrals of the patients who've not done well on basically a lot of the routine. Now, it's interesting that when they come into me, they've all been advised by their eye care provider to use all of the things that we've talked about and the warm compresses and everything. But by the time they get to me, they've forgotten all of that and they don't. So we're really starting back from scratch. And so I always look at each one of them as really a sort of from the point of view of being a detective. What can I find that's really going on and why didn't they respond? So, I mean, you basically go through everything and look, but the key things that stand out for me are, I have had a number that have, for example, an anterior basement membrane dystrophy or epithelial basement membrane dystrophy. They come in with symptoms, fluctuating vision. It's not an obvious one, but when you put fluorescein in, and they have to have enough fluorescein and then just watch the epithelial breakup time, you start to see the lines. And for some of those patients, that's really the cause of their tear instability. And I've done on some of them a superficial keratectomy, and it's relieved their symptoms. Same thing as for Salzmann's nodular dystrophy. I've had some that it basically, by treating that, made the world of difference and made them comfortable again, because it's really altered tear distribution is really what leads to that tear instability. Conjunctival chalasis, the same. And in part, that's inflammatory, and that's usually inferior, and we have SLK, superior limbic, superiorly, both friction-related disorders, but also the superior limbic can give filaments. And so by identifying that you're dealing with SLK, that you can really treat that one, and conjunctival resection for both of those tends to work really well. I've had a number of patients with floppy lid syndrome, for example, that have been referred in. And again, just the realization that those are lax lids, and when you just really elevate the upper lid, it just flips over and you see that papillary reaction. And again, a lid shortening procedure. A lot of these patients have sleep apnea, for example, can make the world of difference. I've had a number with basically mucus fishing syndrome, where a little bit of mucus and then they start going after it. And basically they start this cycle. And I've had one young lawyer who would take her finger and go right into the upper and the lower fornix just to remove it. And I mean, it was the most dramatic you've ever seen in video. But again, coming in with symptoms of dry eye, but until you really ask, well, yes, you have mucus, but what do you do? And then they show you and you say, wow, I didn't realize that people were doing this. And so whether it's Kleenex, whether it's their finger. So there's a lot. I mean, even things like epiphora, tearing. I get a number that are referred, and is it really dry eye with basically reflex tearing? And that gives them epiphora, because we know that tearing is a part of the symptoms of dry eye. Or is it punctal stenosis or nasolacrimal obstruction? What drugs are they are? Is it toxicity, for example, from a medication they're taking? And that's really the cause. And so a lot of these patients with keratitis, and it looks like dry eye, the other thing that I've done is really check corneal sensation. And I think that's something that, we've really neglected to do. And I've been really surprised at the number that have really reduced corneal sensation. We know this can be on the basis of dry eye, for example, the Sjogren's with very severe disease. I mean, they almost have no symptoms, and yet complete corneal staining. But there's an element of neurotrophic there, and in a number of our dry eye patients. And so recognizing that really changes a lot of our our treatment approach. So those are just a few of those masquerade ones. I've had a couple that have been essential blepharospasms that have been referred in because of frequent blinking due to dry eye, and they're basically blepharospasm patients. That botulinum will make a big difference. So I always try to put on my detective hat and see if I can find something that's there that really has been missed that we can really address.
Yeah, and there's a lot. I mean, I was thinking that you might give us 3 or 4, but there's probably like 10 there, right? And I know there's probably others, that you maybe see a little less frequently. I will say that the conjunctivitis thing, I feel like I see so many, especially in the aging population, I see a lot of that. And I wondered how often, like if I see a little bit, should I refer it out to see potentially if it could be repaired or, improved, or does it really need to be like hanging out over the eyelid? Or, in your opinion as a surgeon, how soon would you want me to send that over to you?
I think I'm in exactly the same position as you are. Some patients can have a lot of conjunctival chalasis and no symptoms, and some patients have a very mild amount, and they have a tremendous number of symptoms. It's interesting that if you do an inflammatory, a lot of them will have a positive MMP9. And so that gives you an idea that this, and for some of these patients, is more of an inflammatory process. What I've done, and others have really taught me, is that if you have patients that you've done everything else, they have conjunctival chalasis, they're just not improving, then I think that, one of the simple things you can do is just cautery virtually at the slit lamp and basically shrink down the conjunctiva. And that can be a very simple procedure. On the other hand, you can do a resection, and a lot of times with glue, you can just basically seal these up very quickly. It's a very minor procedure, and they do well. And you're always surprised at how much improvement when you finally make the decision to do something that they get. So yeah. I think we're under treating, but no one really knows how to predict which is going to do well and which is not.
Yeah, that's fair. It is definitely tricky in that sense. But, I have one small comparison that I can make, which is when I was doing my clinical rotation in my 4th year, I was at an ophthalmology clinic in Florida. And there they seem to, I think this is kind of maybe across the country, across the US, there's a distinction between Canada and the US anyways, but they were like, if they saw a little bit, they were like, oh yeah, we're going to fix that. And they'll do a resection like this. And here I've sent patients over to the ophthalmologist and they say, no, we're not going to touch that. And I remember seeing not that much conjunctivitis before when they were actually doing the surgery in the US. So there's an obvious distinction there. And I still have those thoughts in my mind that maybe the surgeon will just go ahead and repair this, but they're not as easy or not as open to, invasive procedures here.
Yeah, and I agree. I think that, and I think that they've taught us to recognize conjunctival chalasis as really a cause of symptoms, where we looked at it as just almost an aging process, and so basically ignored it as a cause when it can be significant. What's interesting is that, in the superior SLK, the superior limbic keratoconjunctivitis, where you get basically that loose conjunctiva up above, what amazed me was you can resect it, and the next day the patient feels comfortable. And yet you have this bare area up above, you flip the lid, it's still papillary reaction. They should be more uncomfortable. Yeah, exactly. They said, oh, at last I have relief. Huh. And so that always amazed me as to what symptoms they can get from that redundant conjunctiva.
Yeah. All right. Well, Dr. Jackson, if there's 3 words that make me uncomfortable, and I'm sure many other people frustrated who are treating ocular surface disease, it's pain without stain. So, this is something that definitely, we had a lot of patients coming in. There's no obvious signs, we're staining. There's nothing showing up under the slit lamp, but they're complaining constantly of this pain, whether they've maybe had laser surgery, cataract surgery, or perhaps they haven't, and they're still just constantly complaining of this discomfort. Some of them coming in with pretty severe pain. This kind of neuropathic issue, how do we pick it up? How do we treat it? If you can kind of help me with this, because I definitely have a bunch of patients who could benefit from me learning a little more about this.
Yeah, no, I can't agree more. And again, returning back to my days of refractive surgery, and I was referred patients that had perfect results, but were just in agony. And when you looked, there was no signs of ocular surface disease, and yet they would be crying because of the discomfort in the waiting room. And we soon learned that, with this is really a nerve problem. It's not an ocular surface problem, but it may start as an ocular surface problem. So in other words, these patients may be in that pre-sign stage of dry eye where they just have hyperalgesia. Their corneal surface is really sensitive to wind, cold, light, and yet you see no signs, and then ultimately they develop more of a dry eye. And in that group, if you put in a topical anesthetic, they feel comfortable. But when you get into the true neuropathic pain patient, you put in a drop of anesthetic and they don't notice any difference. And I just basically say I'm just putting a drop in just to see if it makes any difference. They think I'm putting an artificial tear in. And if they say, oh, wow, that feels so much better, okay, we're dealing with something on the ocular surface. But if they say it didn't really make much difference, then this is really a neuropathic pain. And we do know that a number of patients really have an exaggerated response. I mean, those with chronic pain syndromes, fibromyalgia, osteoarthritis, even diabetics, atopics, any of that group, even those with migraines, for example, can have an exaggerated ocular response, and really you don't see anything. So there is this discordance that occurs with that. And I think, when you get a patient and you suspect that they have neuropathic pain and they may or may not have other risk factors, you really have to go through the whole gamut of dry eye treatment. I mean, I really look at the lids, I look at the surface, I try them on the various things. And it's really only at the end that you can really sit down with them and say, look, we've tried everything from, drops to cyclosporine to serum tears. None of it has made a difference. Sometimes a scleral lens or a PROS type of lens can make the difference too. But, in the end, it's really pain management. Sometimes I referred them to a psychiatrist, and I've had amazing results with a few of the psychiatrists treating these patients over a period of time. And they've actually come back and been smiling in the office where they were crying before. So it's really one of pain management, but it's recognizing that this group, and they need reassurance. They've gone to see 5 other people and they've all said, I don't see anything wrong, and so they think they're crazy. But you really have to reassure them, what's going on. This is a problem. And we don't have really a one treatment, effective treatment for it. It's really to manage pain is really the key.
Yeah, I think that's maybe the frustrating thing about it is we don't have, in many cases we can say, here's an eye drop, here's a pill or whatever, but for this, there's not really anything that we know works. Have you seen, I've read different things about, like you said, serum, like autologous serum drops, or perhaps an amniotic membrane, or even something as simple as, and you touched on this already, omega-3 potentially helping. Would you find those are more for the ones that are, that respond to the anesthetic, that it's more of a topical or surface level thing? Or do you think those potentially could work for the deeper kind of neuropathic type patients as well?
I've been fooled on both. So I go through it for all of them.
Okay,
I don't go to usually amniotic membrane, but I go through to the rest and serum tears and that. Even cyclosporine can increase nerve growth and that. So there may be some function for it as well. I really try sort of all the things, but I tell the patient up front what I think is going on. And if they're willing, we'll go through and we'll try this. I've had some patients that do find some relief, and we haven't cured them, but they're able to function. While there are a few patients, well, as you know, that after refractive surgery, some have gone on to suicide. So, I mean, it could be like the zoster post herpetic neuralgia. It can be that severe.
Yeah. Wow. Well, Dr. Jackson, well, actually, you know what? Before I go on to my last question, I wanted to go back to the omega-3 thing for a second. You mentioned some like a medical grade. I was curious to hear, what type of an omega-3, if you have something specific that you recommend, and what dosage, like how many, milligrams of omega-3 you're recommending daily for patients.
Yeah, I mean, when I first heard about omega-3s, I must say that I wasn't really very convinced that it would help. A number of studies were published. The first one of a medical grade one was PRN that I was introduced to. And the difference between an ester and a triglyceride. In other words, most of the lower priced ones that you can get are in the ester form to take out impurities, but they're not very efficient and they're not well absorbed, and you can get that fishy taste. So if you go the extra mile, you convert it back to a triglyceride. And so that's the medical grade one. Gotcha. And with that, somewhere around 1,500 to 2,000 EHA, DHA, seems to make a difference if you look at the blood levels and the sort of thing that people have done. So, I mean, Sustain makes an omega-3 PRN. There's a number of them out that make a good one. I tell patients to use it if they would like for about a 3-month period and see if it makes a difference. And I have had patients that have faithfully felt it did and stayed on it, and I have others that didn't. I have a lot of patients come in and they say, yeah, I'm taking an omega-3. And so that's really where we have a little discussion and say, you can continue, that's fine. If you want to see if it makes more of a difference, then here are options to upgrade what you're taking and see if it does make a difference. And again, as you know, the studies really have shown some have had benefits, and the more recent ones show that it really didn't. But again, it's a hard thing to assess. And I think that patients should at least be given the option and sort of the knowledge of the types of omega-3s out there.
Yeah, absolutely. I agree. I think education is where it starts. Absolutely. And I think it sounds like I actually have a similar conversation as you with my patients, educating them on the difference between an ethyl ester and a triglyceride, and then, roughly recommending about the same amount dosage wise as you do as well. And it's nice to see that patients, when they get the education, they often will, they understand why you're sharing this information, and a lot of them do come on board with it. Because they're looking, and especially these days, many patients are looking for more of a natural approach versus a pharmaceutical necessarily, or other invasive processes. If they can do a holistic approach, like taking an omega-3 that's systemically going to be healthy for them, they're open to that conversation. But going back to the pharmaceutical agents, this was going to be my last question for you. I'll find, and this includes myself, I find a lot of eye care providers are optometrists are hesitant to maybe prescribe, or maybe unsure even to how to prescribe, or if they should prescribe something like a Cequa, for example. Are there any words of encouragement or anything that you might want to share that might help someone like me to kind of become more comfortable with prescribing these medications?
Yeah, I mean, it's interesting because a lot of my referrals come from optometrists. And they will put patients with dry eye or fairly severe dry eye with keratitis on a topical steroid for a few weeks, one of the FML or loteprednol for a few weeks, and notice some improvement, or maybe not notice any improvement, and then refer the patient. But they stop short of putting them on anti-inflammatory, whether it's Restasis or Cequa. And I look at those drugs as being the safest. They're steroid sparing. And I tend to use them with an induction with steroids. So a 2 or 3 week induction with steroids. Sometimes with the severe ones that I see, I'll start them on a topical steroid and 3 or 4 times a day. And then after a week, I'll add Restasis or Cyclosporine or Cyclosporine, and then just taper off the steroid. So they get an initial really good improvement with the steroid, because we know that it's going to take 2 or 3 months for Cyclosporine to have its full effect. So, as far as a safe drug, couldn't be a safer one, much safer than steroids. So no hesitation there. I think you have to warn the patient of the side effect, that it will sting and burn. We haven't been able to get away from that. If they put it in the fridge, sometimes putting it in cold helps. If 10 minutes later they put in an artificial tear, then that can be very helpful. And then I tell the patients that, they're not going to notice an immediate benefit. And in fact, when you come back and see me in 2 to 3 months, you may not feel much better, but if it's working, I'll notice an improvement in the surface. And then gradually there will be some improvement. But patients look for that quick sort of relief, improvement. And when it doesn't come, then they quit it. And so, one of the ophthalmologists used to say, I make them sort of swear that they're going to use it for 3 months or I won't prescribe it. Because you've got to give it a chance. But I think from the point of view of a safety, for just really spending a few minutes talking to the patient, and if it's purely an evaporative dry eye, and they basically got tons of tears, then I really don't go that route initially. I'll look at other things to try. But for those that have that mix, they have some decrease in tear volume, but also have some lid disease, then certainly I will go to that when they have corneal staining.
Gotcha. And so oftentimes will be part of your initial dry eye plan is to start them on a drop like that?
Yes. I mean, by the time I see the patient referred to me, they usually have had a lot of the basic, but they have stopped it, whatever. So we go over that, but then this is what I'll add next. And so if they don't have much of a keratitis and that, then, I may wait and just reinforce a lot of the other things, see them back again and see how much improvement we've got from that alone. And then start them on the drug. But for those that have a severe keratitis and have been really struggling, yes, I mean, that's really my next approach.
Got it. Wonderful. Thank you so much, Dr. Jackson. There was a lot of really valuable information here, whether it's the history of dry eye, refractive surgery, and pharmaceuticals, or to your more practical advice on clinical approach to treating dry eye. It's really been helpful for me just in this conversation. I know I'm going to go back and listen to it again, because there's definitely parts I can implement right away in our office. Any other final words of wisdom, any other thoughts you'd like to share before we wrap up?
Yeah, I mean, I guess if you're treating dry eye, you really have to spend the time with the patient. I mean, I think that the chair time is really important, because I must say that most of the time they're just given drops and out the door. It does take time, and this is where from our provider like ourselves, we only need 3 or 4 minutes with the patient to assess where they are.
Yeah.
It's really the technicians and the help that can go over how they use the drops, what to use, timing, all of that makes a real difference in whether there's good compliance or not. So that's the big thing that I find. And then I think that, making sure the patient feels that you understand their condition and basically can inform them and give them a rationale of how you're going to approach treatment. May see them back 2 or 3 months later for follow-up and that. I find that this goes a long way in getting compliance from the patients.
Absolutely. I would have to agree with you on that one. And in fact, for that reason, I find there's more than a few practitioners out there who choose not to really dive into dry eye because they know how much chair time and hand holding and empathy and all this that it requires. And that's fine if they choose to practice a certain way, but those of us who do dive into it, we learn pretty quickly. That's a big part of it. Absolutely. So thank you for that. Well, thanks again, Dr. Jackson. Really, really a pleasure to have you on. I'm excited to share this with everybody. And don't forget, everyone, July is Dry Eye Awareness Month. So make sure you get out there and spread the good word about treating dry eye and the importance of it. And thanks again for listening to the 2020 podcast, Canada's #1 optometry podcast. If you got some value out of it, don't forget to share it with your friends. I'll see you again in the next episode.